Hello everyone, this is Ryan Buckley with Greatest Gift Inc. Welcome to our presentation titled, Of Course I'm an Organ and Tissue Donor, Who Wouldn't Want a Piece of This? If you can't tell, those are two kidneys looking their best hoping to get picked up by a new recipient that's been waiting to get off dialysis. Whether you're one of our student leaders starting a donation education campaign on your campus, a teacher looking to start a discussion on organ and tissue donation among your students, or somebody that's just wondering what organ and tissue donation is all about, we believe that this presentation will have everything that you're looking for. If not, you can always visit our website at www.greatestgiftinc.org or shoot us an email at greatestgiftinc@gmail.com. So without further ado, let's get started. Here's sort of a roadmap for where I want to go with this talk. We'll start out with who we are and why our organization exists. We'll discuss why there's such a dire need for organ donors in this country. We'll define brain death and briefly touch on some of the legal considerations of donation and transplant. We'll try to give you a better understanding of the processes of donation and transplant, including something called donation after circulatory death. And hopefully, when all is said and done, we'll have dispelled a lot of the myths that you may have heard about organ and tissue donation. So let's start with who we are. As I said earlier, my name is Ryan Buckley. I've been involved with donation education since 2004 during my time at the University of Florida. Go Gators! I'm a graduate of the University of South Florida College of Medicine, and I'm one of the founders of Greatest Gift Inc. We're a 501c3 nonprofit organization founded in 2007 and dedicated to organ and tissue donation education. Our primary focus is bringing education to college campuses by way of our Greatest Gift campus chapters, but we're always looking for innovative ways to take our campus model and adapt it to education in various other realms, from high schools to places of business, hospitals, and the community in general. This is why we exist. There are currently over 110,000 people on the waiting list for organ transplants, and that number seems to be growing every day. Why is that number always growing? Well, to start, less than half of the country has signed their state's or region's organ donor registry. On top of that, organs can only be donated in very specific circumstances, and there are trained professionals who are always monitoring these circumstances to make sure that organ donation is safe and ethical. When you combine these two facts, you end up with more people needing transplants than there are available donated organs, and then you end up with a net growth in the waiting list of about 5,000 people each year. So how do we start to combat this? Well, if you want to take a pure numbers approach, the average number of organs recovered from each individual donor is between 2.5 and 3. We'll discuss exactly what organs can be donated a little bit later on. Keeping this rate constant, about 2,000 more donors per year would cover that 5,000 person net growth in the list that I mentioned on the last slide. It could even start to shrink the list a little. In order to achieve this, we would have to increase the rate at which people say yes to donation. If 90% of the people who had an opportunity to donate gave authorization for donation, we could theoretically reach that goal. We started gathering those numbers in 2008 when we were first getting started with our campus chapters. And while specific statistics fluctuate from year to year, the general idea remains the same. Here's our most recent update to our statistics. The authorization rate has been slightly but steadily increasing throughout the years. Same with donor designation, which is great. There have recently been less donors, yet more transplants, which is exactly what a doctor wants to hear. Less people dying and becoming donors, yet we're getting closer to maximizing the number of organs we can get from each donor. Now you can start to analyze and ask why these numbers are the way they are. The economy certainly affects everything, and inevitably a drop in the economy means less traveling and less motor vehicle accidents. Perhaps that's why there are less donors. Or advances in medical technology could be the reason why some injuries are no longer resulting in brain death, and thus resulting in donation. Advances in medicine are certainly the reason why we're getting more organs per donor, but regardless of the reasons, the ugly truth still is that there are 19 people dying every day while waiting for a transplant. So why is it that only 40% of the country has signed their organ donor registry, and only 70% of people say yes when approached with the idea of donating their loved one's organs? After 8.5 years of donation education, these are the most common reasons I've run into. Doctors won't try to save my life. I can't have an open casket funeral. Trust me, you don't want my organs, which on a college campus is a very popular reason, especially when the students are still recovering from last night's party. My religion doesn't allow it. I could wake up, The rich and famous get transplanted first. My family will have to pay for it if I'm an organ donor. I don't know how. And finally, I just don't want to think about it. That last one may actually be the most common reason. The rest of these could just be excuses for somebody that doesn't want to have this discussion, because let's face it, talking about your own mortality and what you want to do with your organs when you die isn't exactly cheery conversation. We realize that, but at the same time, that's exactly what makes it all the more important a conversation to have. If it were easy, everyone would be doing it, and then there would be no need for our organization, and there would be no need for me to be sitting here in front of my computer recording this presentation. Listening to me talk about this is one thing, but the most important step in becoming an organ donor is being able to have this conversation with your loved ones, and I'll try to show you why that's important a little bit later on. Once we get past the initial uneasiness of the topic, we can begin to look at some of the other reasons, and at Greatest Gift Inc., we feel that the lack of people signing the organ donor registries comes down to one simple fact. The real problem and the real solution are the same thing: education, or lack thereof in the case of the problem. And that's where we come in. We believe that when you truly understand the process of organ and tissue donation, you'll realize that most of the reasons for not wanting to donate are actually based on myth and not fact. So let's jump right into it. If somebody gets sick and needs a new heart, kidney, liver, or any other organ, where can they get it? Well, one option is living-related donation. This is the typical story of somebody needing a kidney and getting it from their family member or friend. This makes up about 40 to 45% of donors, but only 20 to 25% of transplants, because obviously someone can only give one kidney, or as it turns out, possibly part of a liver. If you try to give somebody your heart or your lungs, you'd be in a whole lot of trouble yourself. Since these usually come from family members, they're typically a better genetic match for the patient, which means it is less likely that their body's immune system is going to attack and reject this foreign organ. Also, these surgeries are usually set up back to back, so there's less time in between taking the organ out and putting it in the recipient, which results in a higher likelihood that the organ will work right away, a measure that's called delayed graft function. Greatest Gift Inc. really isn't needed for this kind of donation, because the education here is done in the doctor's office when the patient finds out that they may need a new organ. Paired donation is a type of living donation that's gained a lot of publicity lately. I'll try to keep it simple, because a picture is worth 1,000 words in this situation. Let's say that recipient A needs a new kidney, and his wife would like to be his donor, but unfortunately she's not a match. Recipient B and C are in similar situations. However, recipient A's wife is a match for recipient B. Recipient B's brother is a match for recipient C, and recipient C's daughter is a match for recipient A. The doctor can speak with all three of these patients and their families, of course keeping confidentiality at all times, and suggest a paired donation to get everyone the organ that they need. As long as the donors are okay with the fact that their kidney is not going to go directly to their loved one, everybody wins. There are some very cool stories out there of paired donation chains with up to 30 recipients. Donation after circulatory death, also called donation after cardiac death or non-heart beating donation, is a rare type of organ donation. We will cover this a little bit later on, but I just wanted to mention it here first since it is a way for a patient to receive a donated organ. Typically, only kidneys are recovered in these situations, and when these organs are transplanted, they have a higher likelihood of delayed graft function, which, as I said on a previous slide, just means that it takes longer for the transplanted organ to function properly. Brain death donors are where most of the organ transplants in this country come from. They make up about half of the donors, but more than 75% of the transplants. This is because 8 different organs can potentially be transplanted from these donors, including 2 kidneys, liver, heart, 2 lungs, pancreas, and the small bowel. Typically, brain death is the result of trauma or anoxia, meaning lack of oxygen, to the brain. These organs have to go from one hospital, where the donor is, to another, where the recipient is, so they need to be stored in ice, resulting in more delayed graft function than living donor organs, but still less than DCD organs. Like all other types of donation, very rigorous testing is done on every potential donor. And as I said earlier, there are trained professionals monitoring these situations to make sure that donation and transplantation are safe and ethical. This is where most of the donation myths come from, so this is the primary focus of our organization's education efforts. To start dispelling some of these myths, we need to first understand brain death. Brain death was first described in 1968. The current official definition is irreversible cessation of cerebral and brainstem function characterized by absence of electrical activity in the brain, blood flow to the brain, and brain function as determined by clinical assessment of responses. A brain-dead person is dead, although his or her cardiopulmonary functioning may be artificially maintained for some time. In layman's terms, that last part means everything is still working from the neck down, but it needs machines like a ventilator to function properly because the brain is no longer telling the body to breathe. Brain death is not a coma. It is not a persistent vegetative state. There is no chance of waking up from brain death. This is a true legal definition of death. Here are some other legal considerations and benchmark laws that make donation possible. First, the Uniform Anatomical Gift Act, which not so coincidentally was passed around the same time that brain death was first described in 1968. Once brain death was defined, people realized that there were organs still functioning in a body that was dead from the neck up. This law basically sets the groundwork for how organ donation works in this country, including how somebody can designate that they want to be a donor, and also outlawing any sale of organs. Another important consideration is gift law versus informed consent. If you've ever been treated by a doctor, you know what informed consent is. The doctor gives you a paper that says you understand the risks and side effects of your treatment, but you wish to undergo the treatment anyway. Organ donation is not a form of informed consent. It falls under gift law, which says that if you make the decision to give your organs as a gift after your death, that only you can change that decision before you die and nobody else. Now, while this is a legal definition, things don't always work out this way. Since brain death is usually in the setting of a tragic accident or suicide, it is very emotional at the time for the family, and the organ recovery professionals always weigh what the family wants very heavily when evaluating a potential organ donor. This is why it's so important to have these conversations with your loved ones now. Some other landmark dates include when the definition of death was legally changed by the federal government to include brain death. As I said before, 1968 was when brain death was first described by a committee at Harvard. Interestingly enough, there's still some room for change in this process, as the federal law defines brain death as being determined by best accepted medical practices. There is no official definition on how to medically diagnose brain death. To help alleviate some confusion, the American Academy of Neurology has developed brain death criteria that are currently widely accepted as diagnostic criteria for brain death. Okay, so we got through all the heavy medical legal mumbo-jumbo. Let's talk about what it actually means as far as going from brain death through the process of donation and transplantation. We'll take a look at a sample case from start to finish. First, let's talk about the players involved. Obviously, you have the donors, recipients, and their families, the doctors, nurses, and the rest of the hospital staff in many different departments. A group that you may not be too familiar with, the Organ Procurement Organization staff, including the medical director of the OPO, transplant coordinator, family care coordinator, and OR coordinator. Now, at different OPOs, these positions may have different titles, but we'll talk about them in generalities as we go through the process. And spiritual care as well, including the hospital chaplains and local clergy. Obviously, there are a lot of people involved here, and it's a well-coordinated process with lots of open communication. And I can't stress enough that that starts now. Being open to talk about this subject with your loved ones is the most important step of all. So for our sample case, we'll look at something I've seen many times. A tragically sad story that ends up in hope for so many others. A 20-something-year-old is in a car accident. When paramedics get to the scene, the patient is unconscious but still breathing on their own. They're brought to the ER and admitted to the trauma unit where their condition worsens. Because of their injury, their brain is swelling, and unlike your leg or your tonsils, when your brain swells it has nowhere to go because it's encased in the skull. So the more it swells, the more it compresses itself, and the damage caused by that is what ultimately results in brain death. The next step is known as the referral. The patient's condition is worsening, and a nurse noticed that the patient is meeting certain clinical triggers, which prompt her to call the OPO. These triggers include things like the type of injury the patient has, different parts of the clinical exam, and whether or not the doctor is testing for brain death. The OPO call center will ask her more questions for the initial screening, and then the transplant coordinator and family care coordinator will go to the hospital for further screening. These are the people that I was talking about that are continuously monitoring the process of donation and transplantation to make sure that everything is safe and ethical. And then the doctor may order brain death testing. Now, as I mentioned briefly a couple of slides back, the government does not dictate how to diagnose or test for brain death. In many ways, this is good because it allows advances in medical technology to add to the accuracy and timeliness of reaching a correct diagnosis without having to go through the trouble of creating a new law. However, having one legal definition of brain death with many possible ways to test for it created confusion among hospitals. To help correct this, the American Academy of Neurology has outlined criteria for testing and diagnosing brain death by using several different tests, including what are known as brainstem reflexes and the apnea test. The apnea test looks at the patient's ability to breathe on their own without the ventilator. Once the patient is declared brain dead, the family care coordinator speaks with the family. In some OPOs, this position is also called the designated requester. They ask the family about their views on donation and how the patient felt about donation. In my opinion, this is the toughest job in medicine, because every day that a family care coordinator goes into work, it's the worst day of their clients' lives. Take our sample case. This was a 20-something-year-old person with their whole life in front of them, and now their family is gathered in the hospital because of a tragedy. You can see why this isn't the best time to make decisions. If our patient and their family had never had the discussion on donation, then this would be the first time they had ever really thought about it. It is very likely in that situation that they would say no, and I would completely understand that decision, especially because there are so many myths out there that give donation a black eye. Luckily for our sample case, our patient was on the organ and tissue donor registry and spoke with their loved ones about their decision, so the family knew that in their tragedy, our patient could potentially save a lot of lives. During this conversation, the family care coordinator, or designated requester, offers to help the family with bereavement and funeral arrangements, even if the family decides against donation. They're not striking any deals here. Everything in donation is a gift. Once authorization is obtained, the care of the patient, who is now called the donor, is turned over to the transplant coordinator, and the OPO covers all costs for the donor's care from that point on. Up until that point, the patient's insurance company or the family is responsible for the costs, but if they decide to authorize donation, they do not take on any extra charges. Now it's the transplant coordinator's job to get the donor's organs in the best shape that they can for the potential recipients. Transplant coordinators usually have some sort of nursing background, but may come from many other fields in medicine. The management of this donor is very similar to that of living patients. They receive similar tests and treatments over the course of several hours to several days in order to get the organs as healthy as possible. Ultimately, they have to prove to doctors around the country that these organs are healthy enough to be put in recipients who have been waiting for a new organ. Once the transplant coordinator has the donor stable and has all the test results they want, they log into a system that's connected to the waiting list. The list is actually several different lists categorized by what organs are needed and how close the recipients are to the donor's hospital. They're ordered based on how sick the recipients are and how closely matched the recipients are to those organs based on blood type and other genetic factors, which we will discuss in a few slides. The transplant coordinator then hits send, so to speak, and sends the kidney offer to the first spot on the kidney list, the heart offer to the first spot on the heart list, and so on and so forth. We've talked a lot about the donors so far, but before we get to the next part, I want to pause briefly and talk about the recipients that are receiving these organs. Just like when we talked about living-related donation, a patient goes to their doctor to discuss their options for a new organ. Let's use kidneys, for example. A patient needs a new kidney, and they can decide whether or not to go on dialysis for a while, try to find a living-related donor, or get put on the waiting list for a donor kidney from somebody like our sample donor case. A lot of different factors go into this decision because a lot of different factors go into the algorithm that decides the order of the list. The primary factor in the The primary factor is the patient's condition. The sicker a patient is, the higher up they are on the list. Also, the longer they've been waiting on the list, the higher they go. If they don't take their medicine, or skip dialysis, or smoke and drink when the doctor asks them not to, these are all things that could potentially move them down the list. These patients can't travel too far from the hospital, and they wear a pager at all times just waiting to get that page about their transplant. Once a patient reaches the top of the list, it is up to their doctors, mainly the transplant surgeon, to decide whether or not to accept the organ that's been offered. The doctor has to use their clinical judgment to decide, 1, if the organ is healthy enough for their patient, and 2, if the patient is healthy enough for surgery. Unfortunately, there's a narrow window there. Because there is such a shortage for organ donors, such a shortage of organ donors, people usually only get transplants when they're pretty sick. But they can also be too sick for transplant as well if the doctor feels that they won't survive the surgery. So the offer has been made to the first transplant surgeon on the list, and they decide whether or not they think the organ is healthy enough for their patient, and if their patient is ready for surgery. If they say, "No thank you, I don't like the way this test result looks," the offer will then go to the next spot and the next surgeon to decide. The process continues until each organ is either placed with a recipient or has been turned down by everyone. In our case, since our donor was a young, healthy person, all 8 of his organs were placed with recipients, and the transplant coordinator, or sometimes a specific OR coordinator, has the fun job of getting several teams of surgeons to agree on one time, usually in the middle of the night, when they can all get to the donor hospital and get in the OR to recover the organs. The travel arrangements are made, and travel arrangements are made for these surgical teams, and they call each of their recipients to tell them to get to the hospital and get ready for their transplant. When all the surgical teams arrive, they procure or recover the organs. Some people may know this as harvesting the organs, but that term really isn't used anymore. This is a surgical procedure, and the body is stitched back up at the end, making it possible for an open casket funeral. The organs are then removed and packaged in special solutions and put on ice. The surgical teams then fly back to their hospitals to transplant the organs. Organs have a certain shelf life, so you can't really recover a heart in New York and fly it back to California because you only have 4 to 6 hours max from the time the heart comes out of the donor to when you have to have it transplanted into the recipient. I don't have a specific reference or citation for those numbers. They're just numbers that I heard from different OPO and transplant professionals. A tissue recovery team may or may not come in after the organ recovery. For our sample case, because our donor was healthy and young, we'll say that they were able to recover everything including skin for burn victims, tendons and bones for orthopedic surgeries, corneas to help restore somebody's sight, as well as blood vessels for many different surgeries. Heart valves can only be recovered if the heart wasn't being transplanted. All of these tissues can then be sanitized and stored for long periods of time before being transplanted. The nice part about the sanitation process is that it limits the amount of medication the recipient has to take after surgery. For organ transplantation, there is no such sanitation process. The recipient has to take daily medications to keep their immune system weak so that they don't try to fight and destroy the foreign transplant. As I said before, DCD is a much more rare type of organ donation. Typically, only kidneys are recovered in this type of donation, and they result in the highest instance of delayed graft function. However, because there is such a high need for organs, especially kidneys, recipients and donors are more willing to take this risk of delayed function, and this type of donation is becoming more and more popular. The important thing to realize about DCD is that all the processes are very similar to donation after brain death, with just a couple of big exceptions. We can bring this back to our sample case and say that the test results showed that our patient was not brain dead, but it didn't look like the patient was going to wake up or regain their normal function. The family knew that the patient did not want to live on machines their whole life, so they decided to withdraw life support. This is the point where the family care coordinator comes in. The decision by the family to withdraw life support is analogous to the doctor's diagnosis of brain death in this situation. And from there, the management, organ offers, and placement of organs is the same as in donation after brain death. Once the organs are placed, DCD and donation after brain death differ again. The patient is taken to the OR, and the family is allowed to accompany them if they like. A doctor from the hospital, with no relation to the OPO or recipients, is there to monitor the withdrawal of life support and declare the patient dead. In order to be eligible for donation, the patient's heart has to stop beating within a certain time frame. If the patient's heart continues to beat past that time frame, then the patient is escorted back to the ICU where they're allowed to pass with their family in the room, or they can discuss other options such as hospice. So now that you have a better understanding for how donation works, let's revisit some of the more common reasons why people don't donate. I think we've shown at this point that most of these don't have facts to back them up. Number 1, the doctors won't try to save my life if they know I'm an organ donor. Most people in the medical community find this one to be kind of silly. The life in front of a medical profession is the most important life. Even for those that want to take a cynical view on things, the doctor treating a patient with a traumatic brain injury has no contact or relation with the potential recipients on the transplant waiting list. Furthermore, they have no control over whether or not the transplant surgeon is going to accept the organ for that patient. A doctor would never put their license and their reputation on the line and sacrifice their patient's care for another patient that they know nothing about. You can have an open casket funeral if you're an organ donor. As we discussed, both organ and tissue recovery are surgical procedures that allow for open casket funerals. Trust me, they still do want your organs. The way I look at this one, even if you're a chain smoker and a really heavy drinker, you could still have a good pancreas or corneas that could really help someone. There are professionals in place to evaluate and test every organ, so if you feel like helping others out by being an organ and tissue donor, don't take the decision out of their hands. As far as religion goes, this one's a little bit trickier, but all major religions have stated that they either view donation as a wonderful selfless gift or a personal choice with no bearing on faith. There are 2 religions that I've come across that absolutely condemn donation. One is Shintoism and the other is Gypsyism. I'm not sure, but I think it has something to do with the belief that a dead body is impure. However, there are sects of Judaism that don't believe in the diagnosis of brain death. They're not specifically against donation, but without brain death, there is very little donation. As far as the reason I could wake up, this one just takes a little bit of understanding about how brain death is defined. You cannot wake up from brain death. The rich and famous do not get transplanted first. That's not to say they don't go out of this country or try to use their money and influence in other ways to find ways of getting organs, but those are the kinds of things that give legitimate organ donation a black eye. The legal recovery and transplant protocol in this country has an algorithm set up based solely on factors such as the condition of the patient waiting for the organ, the time that the patient has been on the waiting list, and their compliance with other treatments. Your family will not have to pay any additional costs if you're an organ donor. The OPO covers all donation-related treatments. If you don't know how to sign up, that's okay, because now you know that the most important step in becoming an organ donor is discussing your decision with your loved ones. To make it official, you can visit our website or the Donate Life America website listed here. You can also register to be an organ donor on Facebook now. And the last one. If you didn't want to talk about it before, thank you very much for taking the time to listen to me, but now I'm passing it on to you. Try to have this conversation with somebody else that doesn't want to talk about it. Ask them why, give them the correct information, and give them a chance to make the decision with their loved ones. If you have any questions, please feel free to visit our website or email us. If you would like a more technical, in-depth look at donation, please watch our next video, Organ and Tissue Donation for the Healthcare Provider. Here are references for the statistics you saw throughout the presentation. Thank you very much.